Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. I am Professor Adam Ahmed Adam. You are welcome to this bacteriology lecture. It is about cholera. It is an exclusive human disease. It affects human only. Cholera is a diarrheal disease caused by the bacterium Vibrio cholerae. The disease, it is mediated by cholera toxin, which is an enterotoxin. This toxin is secreted by this bacteria. The toxin acts on the small intestine, intestinal mucosa, leading to copious of large amount, life-threatening secretory diarrhea. Vibrio cholerae is a saltwater bacterium. Its primary habitat where it lives is the marine ecosystem, brackish water in estuaries. Brackish water is the water that results from mixture of fresh water from rivers and salt water from sea. The bacterium, it is gram-negative curved bacillus, comma-shaped as you see in the picture. It is motile by a single polar flagellum at one end. It is facultative and aerobe. It is killed by the normal stomach acidity of a pH range 1.5 up to 3.5. Its preferred pH is that of the sea water, pH around 8.1. Vibrio cholerae serotypes, so depending on its antigens divided into serotypes. The antigens are somatic O antigen. It differentiates the pathogenic from the non-pathogenic serotypes. The pathogenic serotypes are O1 and O139. The other serotypes are not pathogenic. The other antigen is a flagellar H antigen. This is used in serological diagnosis. This drawing shows the classification of Vibrio cholerae according to the O antigen. The toxin-producing Vibrio cholerae are classified into serotype O139 and serotype O1. The serotype O1 is further classified into biotypes, classical and LTOR. And each of them is further classified into other serotypes depending on the antigens. These serotypes are Ogawa with antigens A and B, Inaba antigens A and C, Hikojima antigens A, B, and C. Transmission. The sources of Vibrio cholerae are man and water. Animals are not sources of the bacteria. The route of infection is the fecal-oral route. The infectious dose depends on the vehicle, in which medium it is transmitted to the gastrointestinal tract. If the infection is through water, the infectious dose, that is the lowest infectious dose, ranges from 10 to the power 3 up to 10 to the power 6 colony forming unit. Colony forming unit means bacteria. But if the infection is by food, the infectious dose ranges from 10 to the power 2 up to 10 to the power 4 colony forming unit. And you see the difference. The infectious dose is low in food or through food, and this is due to the alkalinizing capacity of food, because the preferred pH of Vibrio cholerae is the alkaline pH. Person-to-person transmission is quite rare. The incubation period ranges from 24 to 48 hours. At risk groups, those people who are more susceptible. To start with, people are all ages can be affected, but some have the severest form of the disease, and in this, the disease is known as cholera gravis. These are children, elderly people, people with reduced gastric acidity, people with blood group O. Those are found to be more susceptible than others, and the reason is unknown. Pathogenesis, the mechanism of disease. After ingestion of the bacterium in the contaminated food or drink, they reach the stomach. The vast majority of them are killed by the gastric hydrochloric acid. The bacteria that escape killing reach the small intestine. That are not killed reach small intestine. They colonize the epithelial layer by penetrating the mucus. The penetration of the mucus is facilitated by their mucolytic enzymes that destroy the mucus integrity. The bacteria propel themselves by their flagella through the thick mucosal layer. The Vibrio cholerae multiply and produce the cholera toxin that mediates the disease. The result of disease is diarrhea, fluid diarrhea. So fluid is lost from the duodenum and the jejunum, the upper jejunum. And I'd like to mention that the ileum is less affected. Vibrio cholerae does not invade the bloodstream or tissues. The bacteria just remain on the mucosal surface. But they cause the disease by the produced toxin. We see here, this drawing shows the pathogenesis through the toxins, and on your left hand side, the cholera toxin is made of two subunits A and B. Subunit A is composed of A1 and A2, and subunit B is composed of 5 units. The function of subunit B is to carry subunit A, especially A1, to the inside of the enterocyte, the intestinal cell. Then the A1 activates adenyl cyclase, leading to increase in cyclic AMP, and this will actively lead to pumping of chloride into the lumen. So chloride is actively pumped into the lumen of the small intestine. Then sodium, water, and bicarbonate follow chloride. There will be hypersecretion of isotonic fluid with the same tonicity with the plasma or the blood. There will be huge amount of fluid in the intestine, leading to profuse of large amount watery diarrhea, and the loss may be up to 2 liters per hour. Cholera toxin is an exotoxin. Exotoxin that is produced while the bacterium is alive. It is a heat labile, that is to say destroyed by heat. It is an enterotoxin acting on the intestine. It causes secretory diarrhea, and I have said that the secretory diarrhea, the fluid is actively pumped into the lumen, and it has a tonicity that equals the tonicity of the blood. So watery diarrhea isotonic with the blood, leading to fluid and electrolyte loss. The large amount of the secreted fluid is more than the absorptive capacity of the lower intestine, which results in severe diarrhea. The odor, the smell of the diarrhea is fishy at the beginning, but becomes less smelly and more watery over time. The fluid lost as diarrhea can amount, as I have said, to 2 liters per hour. The diarrhea stool is described as rice water stool. You see the picture. Clinical manifestations: watery diarrhea, nausea and vomiting, but body temperature is normal. There will be dehydration of varying severity. So look at the patient, skin, sunken abdomen, and wrinkles, that's of the skin, loss of skin elasticity, and maybe tissue tear. Cholera occurs as outbreaks, epidemic, pandemic, or sporadic. Since 1817, the world witnessed 7 cholera pandemics. The first 6 occurred from 1817 to 1923. They were caused by the classical biotype. These pandemics originated in Asia with subsequent spread to other continents. The 7th pandemic began in Indonesia in 1961 and affected more countries and continents than the previous 6 pandemics. It was caused by the biotype L2. Diagnosis: clinical. The laboratory investigations: the specimen to be collected, the real stool, microscopically in dark field illumination. You see bacteria with darting motility, let's say with rapid motility, and there will be no pus or red blood cells. So absence of pus cells and RBCs. In gram-10, gram-negative comma-shaped bacilli, the alkaline peptone water is used as an enrichment medium. The stool specimen is then cultured in thiosulfate citrate bile salt sucrose agar, PCBS agar. It is a selective and indication or indicator medium. So you look at the picture. Serology tests are used to identify the serotypes so as to trace the source of infection. Treatment: the most important point or step in treatment is rehydration. Restoration of fluid deficit to be completed in about 4 hours. The maintenance of the ongoing fluid loss. If the area is going on, you replace the amount lost. Fluid for rehydration: ringer lactase solution is the best because it also corrects the metabolic acidosis. The second, normal saline through the intravenous route, used for severely dehydrated patients and those whose diarrhea is more than 10 ml per kilogram per hour. Then if the patient is able to take by mouth, you will give oral rehydration salt solution. You liberally use to drink as he or she needs. Drug treatment: it takes a matter of 3 to 5 days. The aim is to get rid of the bacteria so as to stop more toxin production. For adults, tetracycline, doxycycline, cotrimazole, and ciprofloxacin, any of them can do the job. For children, erythromycin, cotrimazole, and furazolidione, any of them can do the job. Antibiotics should be started when cholera is suspected, that to say on clinical diagnosis, before lab results, so as to stop the toxin production. Prevention: health education on hygienic practices, improvement of personal and environmental hygiene, provision of safe water, safe disposal of excreta, antibiotic prophylaxis to household contacts of index cases, vaccination. Vaccinations are oral vaccines, killed and life attenuating. They give limited declining protection. So the protection will wane out by time. And the vaccination is not, these vaccines are not alternatives to protective measures. By this, the lecture is over. I hope that it is understandable and I wish you all the best.